Hell yeah. Hell yeah.
Excellent. Okay, we are live.
Awesome.
What's interesting, it's only showing you, Alberto. Now, so it switched to me when I spoke. Okay.
So on my end, it says you're in a practice sessions. Attendees cannot join until you start the webinar.
That's right. So I'm going to be starting that here in a few seconds.
Okay.
But we are live streaming currently on YouTube, just so you know.
Cool.
Okay. I'm going to go ahead and start the webinar so that people know it's getting ready. And it's going to show this background, okay?
Okay.
All right, guys, here we go. Okay, I think we're going to go ahead and get started. We're after 6 o'clock. This is the OrthoBiologics Epic Duel Part 1. We're going to get started here now. But first, I think it's very important to say welcome to absolutely everyone, especially our friends around the world. I'm proud to say that we have had over 20 countries represented in our attendees tonight. And that is amazing. So thank you so much for taking the time to sit with us tonight, especially those of you who are so late at night. I just received a wonderful message from Greece, and I know it's probably like around, I believe it's 3 a.m., I believe, over there. Thank you so much for staying awake for us. Also, remember, we will have this live streaming on YouTube, which will be available later. So if you get exhausted and want to sleep, please feel free, get some sleep. But again, thank you all for being here. Oh, 4 a.m. Wow, my apologies.
No.
So, in case you don't know, my name is Hirahara. I'm the medical director, head team physician at Sac State and the River Cats here in Sacramento, California. I'm a very busy orthopedic surgeon in a private practice. I do a lot of work on orthobiologics. I teach, research, publish, and I've been doing this with orthobiologics for at least 2007. We also have, these are my disclosures. And of course, we have Dr. Alberto Panero, expert international speaker, claims to be man of mystery. However, I think we'll see tonight during the debate, that's very, very questionable. Interventional orthopedics, orthobiologics, core faculty, UC Davis Sports Medicine Fellowship, team physician for Sac State, Sac Republic, and the Sac River Cats. His disclosures are here. And of course, last but not least, Dr. Kyle Yamashiro, PT, DPT, all around awesome dude, president of private practice physical therapy clinic in Sacramento, Results Physical Therapy, affiliated with many Northern California colleges and professional teams, expert on rehab, following orthobiologics. He has presented nationally over the past 10 years on this topic, working together with us for many years. In fact, I've known him probably too long, 20 years. He has written all of our protocols in orthobiologics and done some great work. He has no disclosures. You better get busy, Kyle. But the dual format tonight, we're going to pose a question or a topic. We're going to get 1 minute to give our opinion. Then after that 1 minute, we're going to cut them off. They go on to the other person. Then we'll have a little discussion about rehab. And then we're going to ask you, the participants, to please participate. We're going to be sending out polls on every single question. We want to hear from you, what you think, what is really like the kind of general trend of where people are going with this. And then we're going to have 1 minute of a consensus discussion. We're going to try to get through 13 questions tonight for both questions in fact and fiction. And we're hoping that this is going to be a lot of fun. This is the duel. And primarily, as you know, Alberto and I are going to be going at it. We might get a little feisty. It's okay. We're friends. Kyle will be there to kind of break us up, stand between us, take the punches for the other guy. I like it. But the polls are going to be anonymous. But we really want this interactive. We want you to please, give us your opinions. And we want to try to reach some type of consensus for each topic and question. And also, please remember, we'll be doing a discussion at the very end. So if you have questions you want to kind of pose to everyone, please put it in the Q&A. The Q&A is going to be a button at the bottom. As you know, there's a chat, raise hand, and a Q&A button. So we're asking for people to go ahead and put it in the Q&A. We'll look at that at the end and try to answer as many questions as we can. Of course, we're going to have an after survey. Please fill it out. Please let us know how you hate us or love us. Hoping you love us someday, hopefully someday. And we are live streaming this. So it is being live streamed at youtube.com/HiraharamD. And of course, it will be available there in the future. So if you ever want to go back and look at it, it will be there. And of course, we'll have it on our own websites as well to show. Also, going to get a plug for the part 2. Today is the essentials. Next week, we're going to do the controversial and advanced questions. So same time, next Thursday. Hope to see you all here. If you have registered for today's conference, you will be automatically registered and get an email to go ahead and join us next week as well. We hope you can join us. Again, if not, it will be on the YouTube channel afterwards. So let's get to it. Round 1, the questions. And the first question is, what's more important, the stem cell or the platelet? So I'll start us off. I got 60 seconds on the clock, and so let's go. For me, what's more important is talking about the whole cascade. It's about the healing cascade, going from injury to inflammation to proliferation to remodeling. But within that concept, you have the clotting cascade, platelet aggregation, anti-inflammatory cytokines, and of course, then influx, migration of the stem cells. So it's not about what's more important, it's a whole cascade. You need each subset unto itself. It needs to all be there for it to work. And of course, the white cells and complement system is there as well. But platelets stop the bleeding. They stop the process of inflammation. They start the process of regeneration. It's the white cells that do the inflammation, and it's the stem cells, which we think are going to do regeneration. So they're all important. We need them all. They each have their own goal. That's why we have all of them. So the problem that for me is, if we're going to use them, we have to determine what our goal is and then use the right aspect of it. Okay, Alberto, you're up.
You made some great points, and definitely they're all important, but I do feel the stem cell is the most important. Why is that? Because it's the quarterback of the body's innate regenerative potential. And yes, I want Tom Brady on my team. I want the quarterback. I want to win the Super Bowl, right? So I do think that, having said that, we have to pump the brakes a little bit on the stem cell term and kind of try to readdress the concepts, because it's not so much the ability of the stem cell to differentiate into the tissue that you want. For instance, when I inject them, they don't turn into cartilage, they don't turn into tenocytes, but basically they engraft themselves and they modulate inflammation. And as you can see here, bone marrow concentrate has much higher quantities of the same growth factors as PRP. So because of that, I do think we have to be mindful that these cells may be called more medicinal signaling cells because they don't really retain their stem capacity. But they're still the quarterback of the body's regenerative potential. And I think at the end of the day, if you have to pick one, I'm going to go with the stem cell.
So we're going to start a poll. We're going to go ahead and send this out to everyone and see what everyone thinks. So here comes poll number 1, launching now. And we're going to put 10 seconds on the clock. All right, we're going to close the polling here. Got a few people straggling in, and I'm going to share the results. So we've got 38% of people thinking stem cells are more important, 14% platelets, 44% both, and 5% I don't know. So let's go ahead and get into talking about this. Guys?
Well, I think you made some great points. They're both important, and it is all about activating the body's immune response to an area, and different things are going to do different, they're going to perform different roles and different functions. So I do feel at the end of the day, for me, like I said, the stem cell is important, but we need the whole complementary system as well.
I think another thing you need to think about, though, Alberto, is that if you're going to figure out which one you want to use, like let's say we want to harness them and use whatever property each one has, I think it's critical to know where it all lies. So like, let's say we just want to diminish inflammation. Well, platelets might be just fine. We don't need the stem cell. But let's say we want to regenerate tissue. Well, the platelet's going to call the stem cells, but the stem cells are going to do the work. So putting them in place might be better.
Yeah, I agree. Go ahead, Kyle.
Hey, I think that for me, when they're coming over, if I have somebody coming over with stem cells, I'm going to be a little bit more conservative, take a little bit my longer time. If it's somebody with a platelet.
You got cut off there, bud. Finish your sentence.
I'm good. You guys get
Let's keep going. We got a lot of questions.
All right, let's move on then. Round 2, question 2. Is anti-inflammation or pro-inflammation preferable in healing? All right, so I'll start off again. For me, leukocyte-rich PRP, and that's kind of where this question comes in, is been discussed as being something that's so important. There's many studies out there that say, oh, it's really good, but we have to understand that white cells are our inflammatory response. They're our defense. So we know that it's going to cause inflammation. It's going to increase MMPs, those inflammatory markers, and it's going to increase cell death in synoviocytes. In fact, we did a study and looked at leukocyte-rich PRP in POSTA repair, in shoulders, in partial cuff repairs. And we found that if you use the leukocyte-rich, we had these increased amount of tear-throughs by our high tensile strength sutures. So we determined that those white cells were causing a weakening zone of weakness in the actual tissue. So for surgical, it's bad. And so we also know that since PRP can actually modulate inflammatory response. It'll decrease pain, inflammation, promote stem cell migration. Surgically, we have to go only with leukocyte poor.
Sure, but I do think that inflammation can be good at times. And if we look at leukocytes, there's various, right? There's 5 different types, and it may be that some leukocytes are okay and some are bad. For instance, monocytes appear to be good for healing, while neutrophils are probably bad for healing, right? But if we look at tendinopathy and we stick to the level 1 data, I mean, we have to follow that, right? So for tendinopathy, I think we have to go pro-inflammatory leukocyte rich, and Dr. Fitzpatrick published this meta-analysis that proved that, okay? That really shows that leukocyte rich is better. But you do make a good point that sometimes we don't want inflammation, and that is true for osteoarthritis, and that has been proving in the literature as well, because if we look at the data, most of the studies that use leukocyte-rich PRP for osteoarthritis, no difference, but the benefits came when we used leukocyte-poor preparations of PRP in knee arthritis. So for me, tendinopathy, leukocyte-rich, go inflammation, osteoarthritis, leukocyte-poor.
Yeah, well, okay. So I've been working with Dr. Hirahara since 2009, and you can obviously tell that he's been using leukocyte poor, especially like with tendons. Like if it's being injected into the tendon, we skip that inflammatory phase and we go directly to the proliferative phase. So we still want to, be very, very conservative in those first weeks. But when you started coming along and you started like bringing in this leukocyte-rich stuff and it started going into the tendon, these people came in hurting, like immediately hurting. So whether it was into the lateral, the common extensor tendon or flexor tendon, or into the Achilles, these people were in a lot of pain. So, but at the end of the day, when you get down to the remodeling, both of them had pretty good outcomes. So for me, it's just kind of, we have to still follow our protocols and respect the healing cascade. So if that's your preference, we're going to respect that preference. And then we're not going to ice that patient. We're not going to try and remove the inflammation from that area. And we'll allow the inflammation to happen. We'll allow the patient to hurt. And we'll let the patient know it's going to hurt.
Man, it sounds like you're siding with Hirahara there. I'm gonna have to take note of that.
No, I'm not.
As he should. He should.
I see where this is going.
No.
Well, Alberto, you should know already how this works.
Yeah, we'll
All
see
right,
about that. Let's
here we
check
go
out
with the poll. Is anti-inflammation or pro-inflammation preferable in healing? Let's launch the poll and let's put 10 seconds on the clock.
What's it gonna be? It's gonna be tight. It's gonna be tight.
Oh,
All right, let's share the results. So anti-inflammation preferable 14%, pro-inflammation 20%, depends on the situation 63%, 3% I don't know. Yeah, you know what, Alberto, honestly, I think that's very reasonable. And I think that's a good point that sometimes you need it. And I've also said in times, if you have like a diabetic ulcer and you're going to use PRP to help modulate the response, get better healing, actually use the white cells as they're supposed to be used to help debride the area. I agree. But from a surgical point of view, that is absolutely a contraindication. And so you cannot do that. You can't use white cells.
and to Kyle's point, I have to educate my patients and let them know that it is going to hurt. I have to prepare them for that. And that's why you have to work one-on-one with the therapist, so that way when they receive the patient a few days later, they know how to calm the inflammatory response down and don't do things to make it worse.
Yeah, and for us, I mean, honestly, when somebody comes in with pain, especially in a localized area, my first instinct is to try and put ice on it and to try and decrease that inflammation. So it is actually hard for me to just kind of like let that the injections just kind of stay there, and that's the most important thing. But I think that's the hardest thing for me is to white ice.
Fair enough.
All right, let's move on. Do anti-inflammatories help or hurt the healing process? Alberto.
They heard it. And there's definitely multiple studies that show this, even a recent meta-analysis from 2019 that showed effects on bone healing. Also, there's negative effects on tenocyte proliferation, and it's been associated with the progression of OA with long-term use. And that's local effects to the area that you're trying to heal. And we all know about the negative systemic effects, GI problems, kidney problems. and it's been associated with hypertension, stroke, and heart attack. So I don't understand if we're doing these treatments to get people off anti-inflammatories, reduce pain, make them better, why we would put them back on anti-inflammatories afterwards. I think we could all agree that prior to an injection, you want to get them off your anti-inflammatories, but afterwards, what's the point? Why would you put them back on anti-inflammatories? You just did the injection to try to get them better.
So,
Yeah.
Alberto, I'm glad you put a self-portrait up, because truly you are a goat. Now, it is true that they have negative effects, but there are positive effects as well, and that's what you're missing, is that they are analgesic, anti-inflammatory, and antipyretic. Now, granted, they do prevent platelet aggregation, they do prolong bleeding time, so before surgery, before a PRP, before a stem cell, I always stop at anti-inflammatory 5 days before. I don't want increased bleeding. However, the however is, it doesn't affect truly bone and soft tissue healing. It really doesn't. Most of the studies pretty much have debunked all that. The original study looking at bone inhibition was actually in monkeys and rats. So that's not something that has been shown much use in humans after 2005. Also, most of the studies don't show any effect on labrum, tendons, and ligaments. And the thing that you're missing is that I will only do the anti-inflammatories for a few weeks, just like Kyle said, to drop the inflammation. So the goal is, after a surgical, especially a surgical intervention, we want the inflammation gone. And also I'm using leukocyte poor, therefore no inflammation. So let's poll the audience. Let's see what everyone thinks, okay?
This is a good one. This is a good one.
This is a good one, and it's a good discussion, good argument. It has things on both sides, but let's see what everyone thinks.
I'm staying out of it.
10 seconds on the clock. All right, got a few stragglers coming in. Send the polling and let's share. All right, looks like the majority think it hurts the healing process. They clearly weren't listening. Just kidding. but the second most say depends on the situation, which actually I think is true. And of course, the 40% say helps. It does help in certain situations. I would agree with that. So unfortunately, I think this is a situation, Alberto, and I think we would agree that it really does depend. And I think there are situations where anti-inflammatories are really beneficial. I agree that long-term use is not a good idea. I think we all are very clear on that. And I agree that trying to get them off as quickly as you can is good. But I think with just like using ice, they have their purpose, they have their use. You just have to time it right and use it appropriately.
Well, and you bring up a good question with ice, right? Because I think we differ on this too. For me, with biologics, you're trying to activate the body's immune response to an area. So whether you use leukocyte poor, leukocyte rich.
Hold on, immune response? Hold on, immune response? That's not the same thing.
Fair enough. Okay, you know what I'm trying to get at here, and you don't want to shut that process down, right? So that's why I don't want to shut that process down by putting them on anti-inflammatories or using ice.
Hey, so I got a question here. You guys both make great arguments. If I'm talking to my patient, what am I supposed to tell them?
Tell them Panero's wrong.
Okay.
Tell them they're going to follow.
Yeah.
I think at the end of the day, you know, from a physical therapy standpoint, you know, you should respect the surgeon or the doctor who did the procedure and their protocol, unless you feel like it's completely off base.
Which it could be. It could be.
It could be, and then you should contact the doctor, right?
Yeah. No, I think it's a good discussion. That's kind of the key point. It's a good discussion.
Yeah.
All right, next question. For tendinopathy, is injecting regional or specifically better? Meaning, are you going to shotgun it or sniper rifle it? All right, so for me, it's all about what's the diagnosis? What are we trying to accomplish? So we have to be better at finding out what's wrong and applying the proper application of treatment to what you're doing. And that, for me, is making sure not just good diagnosis, but good imaging as well. And for me, ultrasound, especially on soft tissue injury, has really been good. So, for example, looking at a normal tendon, then a fusiform swollen tendon versus just say an actual partial tear of a tendon is all different. And we're going to treat them very differently. And so by just generally rapidly throwing in a needle and trying to get to heal is not a good idea. And we're going to talk about how cortisone is detrimental to this, even more so trying to put that there. But for me, it's about being point specific, being able to find out where the problem is, apply the proper application of the proper treatment to the proper spot after discussion of what our goals are of what we're trying to do. So again, it is all dependent, but overall, sniper rifles better.
I hate to agree with you, but I got to agree with you on this one. For me, it's 2021. If you're doing biologics, they should be image guided. On the left side, you can see there a partial rotator cuff tear. You want to get your sniper rifle out and you want to inject into the defect, right? But let's say that same tear is on an older patient, maybe 78 with some degenerative changes. Do you really want to inject your tendon, flare them up, and then slow down the rehab process? Maybe you shotgun the area and just flood the subacromial space with leukocyte poor PRP. And with that, just try to provide an anti-inflammatory effect, and maybe that'll be more beneficial for that type of patient. Which also brings me to shotgunning the problem. For instance, in the spine, a lot of times we'll use cortisone and we'll inject the SI joint or the facet joint later. And if that doesn't work, maybe do an epidural if indicated. But I think when we look at the spine, we can treat it as a unit and do all of these injections at once, where we address the facet joint, the SI joint, and if indicated, the epidural space, and just do them all at the same time.
Yeah, and I would say the most important thing for me is to find out what you did for the injection. What was your indication for the injection? Because a lot of times we'll get the referral that just says PRP to the shoulder. So we don't really know. But if we know that we have an active person that can still perform their activities, such as the guy on the right who might have some patellar tendonitis, he's still able to play. Don't shut this guy down. He's their main scorer. So they're allowed to have immediate range of motion, return to activity after 3 to 4 days. Then I would say that this is actually a better use instead of a cortisone injection, because I can get back if it bothers me again in 2 weeks, throw another PRP in there. But if it's going to be like the girl on the right, when we know that you're going to heal the tissue and you did a sniper rifle, well, then we have to start the whole healing cascade with the proliferation, filling in the defect, increasing the tensile strength, and remodeling, and then to let the patient know that this is going to be about a 6 to 8 week process. Oh, that was perfect timing. Boom.
Perfect time. Right on.
First time ever.
Yeah.
All right, let's do the poll. For tendinopathy, is injecting regional or specific better? Let's get this poll going, and I will release it now. 10 seconds.
9, 8, 7.
All right, let's end the polling and see what we got. Share the results. All right, so this is overwhelming. Specific 68%, depends 29%. And I think there is a definite depends. I think that's reasonable actually to do. Also, let's be clear, Alberto. I mean, you introduced a new concept, a little bit different from what I meant. Shotgunning the problem in the region as opposed to shotgunning an injection. Tell us a little bit more about that.
Yeah, so like I said, I feel like you should always do this image guided, right? But at the end of the day, you have to take the whole patient and the whole situation into consideration. And also that, unfortunately, for the most part, these are out-of-pocket expenses. Thus, you can't keep bringing the patient back for multiple injections. I mean, you could, but it becomes a little bit cost-effective. So that's why just shotgunning the whole problem at one time sometimes can make sense.
So what if I would say in the injection in the primary care office, if you don't have these available to you, if you don't have an ultrasound unit in there, then what are some of the other options that you can do?
Yeah, it's a great point. I feel like you got to go back and learn the technology. I learned ultrasound in my residency and fellowship. I didn't get much fluoroscopy training. I went back. I knew that I needed it to do spine and intraosseous work. I took the courses, I went to the labs, and then I just started doing it, as safe and as I best I could. So at the end of the day, if you want to be legit, you got to go back and learn the stuff.
I think, I'll take 10 seconds just to say,
Sure.
I do think ultrasound in this situation of doing injections is a standard of care. And I don't think in today's world that doing it without image guidance is reasonable anymore. And especially when you do cortisone, and we'll talk a bit about that later, where you really need to be point specific and not hit structures which you're going to damage if you get in the wrong area. So that's just kind of my feeling at this point. All right, and here we go. Can I use lidocaine, cortisone, or HA with OrthoBiologics?
All right, I'll start with the first part of the question. Cane toxicity, because of that, no. I wouldn't use lidocaine. I wouldn't use ropivacaine or bupivacaine. If anything, you could create a skin wheel. I think a better option is to do a regional block. And I think that you could get away with that a little bit better and not harm your platelets or your stem cells. Combining with hyaluronic acid, I think that's a big yes. For osteoarthritis, there are studies that show that they are synergistic treatments. They make each other better. So I'm a big proponent of that. But I want to introduce a concept of combining by other different types of biologics. For instance, in this case, I had a patient who had a plantar fascia rupture, and I was concerned that if I injected the bone marrow, it would just flow in and out of the tear. Because of that, I micronized a little bit of her adipose tissue, and I injected about a half a cc of micronized adipose into the tear first. And then I followed that up with the bone marrow concentrate injection, using the fat as sort of a scaffold. And I think that this is where this technology is going.
Yeah, and from my point of view, this is what I've been kind of alluding to the whole time, is that cortisone has a lot of negative effects. And so I'm very much against this kind of a drug, that it softens and damages cartilage, weakens and rupture tendons, gives you AVN or thinning of the bone, increase your risk of infection, diminishing the activity of the immune response, increasing your blood sugar, gives you fat atrophy, crystal deposition, steroid flare, etc. So to me, this is no longer, with other options, a viable, good first-line drug. It's just not when you have things that have essentially no side effects like PRP. And the cytotoxicity of canes, again, we've talked enough about it, not something that's good. And what's interesting is Gus Mazak out of UConn showed us very clearly that when he used PRP, he saw significant tenocyte proliferation after 5 days. However, when he combined it with cortisone, he had a significant diminishment effect. With the canes, zero effect. It basically killed off the cells. So let's send the poll out.
Do it.
Let's do it. 10 seconds. Okay, share the results. Pretty much overwhelmingly HA, lidocaine, cortisone, all the above, a few stragglers. At this point, Alberto, what's your thinking here? What are you thinking where we are?
Well, I think probably the biggest, I guess, point of debate is the lidocaine, because I still, with a lot of folks that do biologics, they are still using lidocaine. I think if anything, you want to use ropivacaine, which is not as acidic, and maybe mix it with some saline first to dilute it. But again, for me, I would only do the skin wheel and go into the and create a track. Regional blocks for me, especially if you know how to use ultrasound, are much easier to do, and it's not going to affect the area you're injecting.
So can I inject here? Like, if I have a patient that is actually improving, but still needs a little bit more, like maybe like 25% more improvement, and they're setting up for an injection, do you think that having a cortisone injection first, because it's covered by insurance, and then they can go, and if that doesn't get better, can you go in and then spend the money for having a platelet or a PRP injection?
So that's a great question, Kyle. The problem, and I'm going to just stop the timer for a second so I can answer this as I can. I think the problem here is that cortisone deposits crystals. If you were to do a cortisone shot first, say a lateral epicondylitis, if you give a PRP injection following that, subsequent to it, unfortunately, it kind of like doesn't work as well. It kind of inactivates and deactivates the PRP. And so you'd have to give 2, 3, 4 shots of PRP to overcome the cortisone effect sequentially. And we'll talk a bit about what that's needed. But if you're going to do that and you want to use both options, doing the PRP first does not burn your bridges to do cortisone later. But doing cortisone first burns your bridge to do PRP later. So that's why I say I think cortisone has some significant issues. And if you can avoid doing it and do other options of biologics, I think you're better off for the patient.
Hey, Alan.
So is there a time to it? Like, is it like two months before they had cortisone, 6 months, or a year ago?
Yeah, that's a great question. That's controversial right now. And for example, there's a lot of studies that are looking at cortisone use prior to rotator cuff repair. And it's becoming clearer and clearer in the past 3-4 years, with more studies coming out, that if you do a cortisone shot prior to cuff repair, your chance of failure and having re-tear are significantly higher. And it's looking at there is a time course. So the sooner you do it prior to the surgery, the greater the chance of rupture. Also, the greater numbers of injections you do, the greater the chance of re-rupture and re-tearing or failure of your repair. So there's no doubt that there is a time course limitation. There is a dose response limitation. those are great questions, but that's kind of why I'm so anti-cortisone, is because it's become such a problem. And when people send me patients to do their cuff repairs, I really don't want them having had a cortisone shot, or I will literally make them wait a few months before I'll go do their surgery.
Wow.
Yeah.
There, I did my minute.
All right.
All right, last question from the question round one.
It's so hard not to want to keep commenting. I got to tell you, this
Yeah,
1 minute
I know.
thing was crazy.
So much to say, I know. And also I want to argue with you some more because you're wrong, Panero. Anyways. All right, OrthoBiologics, still experimental, investigational. Okay, I'll start us off. This is all about history, okay? The first time PRP was described in the literature was by O'Brien in 1969. And then it was used in open heart surgery in 87, and meniscal repair in 88, and then the oral surgery and dentistry industry used it a lot in the 90s and published a lot in the 90s. And then eventually the FDA actually approved it for use in the US in 1999. So it's been FDA approved for over 20 years. It's been in the literature for over 50 years. I don't know a single treatment that continues to be used for over 50 years that people consider experimental, investigational. So I have a serious problem with that concept. So from my point of view, and having used it now in literally thousands of cases, this is not fairy dust. This is stuff that does work. The key is understanding how to use it, when to use it, the best method to use it, because the technique of getting it and using it and implementing it matters.
There is nothing I hate to continue to agree with you, but I agree. It is not experimental, but we have to look at what are we using it for? How are we using it? For osteoarthritis, there's over 140 studies for knee OA. Unbelievable, right? And several of those are level 1. So how many studies do you need to prove that this stuff works, that it reduces pain, it improves pain for up to a year or even more? Tendinopathy, same thing. There's at least 37 level 1 randomized controlled trials showing what it works for, what it doesn't work for. But I think we have to be mindful with other orthobiologics like bone marrow micronized adipose tissue. Those don't have the body of work that PRP has in the literature. So I would say those, for the most part, still to continue to be experimental, but PRP specifically for knee OA, gluteal tendinopathy, and common extensor tendinopathy, not experimental. And for me, should be first line of treatment in a lot of cases.
Yeah, well, I mean, I think when you're talking about the research on orthobiologics, let's talk about the research in orthobiologics in orthopedics. So that's still relatively new. So when you look at the published randomized control trials since 2010, there are only 13 that were performed. So more recently, you're seeing 2017 to 2019, in which there are about 45 of them. So I still think it's a little bit new, and but we are starting to get some better data. However, with all of this, there are a lot of mixed results of the effectiveness of the orthobiologics. So a lot of this is due to because it's based on questionnaires on functional outcomes with or without PT. And I think there's a big adjunct with physical therapy following an injection. But when you look at the rehab and the studies coming out of there, there's only 12 articles since 2015, and there are 0 level 1 research. So I think as far as rehabilitation, we still have a long way to go to substantiate our protocols following the injection. It's just very difficult to set up a level 1 study.
All right, let's send out the poll.
All right, let's see.
See what people think. All right, let's share the results. So the winner is no, but very close behind depends on the use, which I think is very much legitimate and very reasonable to say. I think in the end, that's really a key point. And I just like to kind of like start off by talking about what Kyle said. I think he had a great point that the number of randomized controlled trials is relatively limited. And of course, the key point, mixed results. But I think the big problem with the mixed results is that, unfortunately, a lot of people didn't know how to use this, and the actual study protocol and paradigms were wrong. Like, if you're trying to shove PRP on top of a rotator cuff repair as opposed to in the interface between the tendon and bone, it's not going to work. That's my problem with that.
Yeah, and also, go ahead, Kyle.
No, and I think that you're looking at what type of specificity are you injecting and where, and what protocols are following it. So I think when you look at those studies from 2015, they're basing their techniques from 2010, in which there wasn't any technique. It was just kind of a Wild West.
Yeah, I'm gonna leave it at that because I don't want to be eaten by the monster.
Right. All right. So that's the end of round one, guys. Great job. Great work. We're a little behind the time, but doing really well. I want to put a little plug in for next week. Remember that next Thursday, 6 to 7 p.m. Pacific time on the West Coast, California time, we'll be doing our controversial advanced questions. This is something I think is going to be a lot of fun. Again, we're kind of covering some of the essentials today, but next week we're going to kind of go really after it. At this point, remember, everyone tonight who's here will be registered for next week's webinar. These are our questions. They're going to be a little bit more complex, whether OrthoBiologics slow or stop DJD from progressing, whether you can inject or should inject intraosseously when they're given a DJD injection, what's the role of individual anti-inflammatory factors like IRAP or platelet lysate, do orthobiologics promote scar formation, injecting orthobiologics to uncontained partial tears, can they help heal or avoid surgery, or is having an autoimmune disorder a contraindication to orthobiologics? So we're going to go into a lot of fun, difficult, controversial questions. We may not necessarily have the answers, but we'll give our opinions about what we think and give some of the more recent literature about where we are. Now, let's get to our fact and fiction round two. And these are questions, having lectured now over the last 13 years on orthobiologics, that I've heard a lot around the world, and Alberto likewise has heard this. And so we kind of took some of the more common questions we get out there and kind of put them into this little thing. We're going to kind of go through whether we think this is fact or fiction. Okay, first question or first statement: stem cells are found in the blood.
All right, for orthopedic purposes, I got to go with fiction. They are not found in the blood. We use blood to create PRP. But if we look at where are they, where do we found them? MSCs are pericytes. They're essentially in most of the tissues in our body. And when there's an injury to the tissue, they migrate to the area and do their thing. For us, we like to get them either from bone marrow or adipose. I think there's pros and cons to both. Bone marrow, when well done, could be actually well tolerated, but sometimes it gives you a little bit of a smaller volume. That's why adipose, when you're doing multiple body parts like multiple joints or tendons, may give you a better graft. And also, if you look at the basic science, it does have higher quantities of MSCs, but with the systems we have allowable in the United States, you're not actually really ripping the cells off the fat. For that, you need to digest them with collagenase, and we can't do that here. So both good sources of MSCs. I think that you should know how to do both of them, and depending on your case, pick one you want to do.
So for me, this is fiction as well. Likewise, I don't like agreeing with Panero unless he's just agreeing with me. So the thing is, stem cells actually, what's interesting is they can be found in blood, but there's only a specific situation. It's when they're released during high intensity exercise, or when there's a significant injury, and actually they're mobilized into the blood sometimes to be able to go to the site of need. However, under normal circumstances, Alberto's right, they're not found there. The key is, where are vessels found? Vessels are found throughout the entire body, and so these stem cell niches is where we're going to be looking. And the niche is where there's a high concentration of vessels, because it makes sense, right? If you want the cell, which is going to help you heal, be able to be easy, it's got to be somewhere all over the body, and vessels are all over the body. So going for the bone marrow, the adipose, that's where we're going to have the highest concentration of finding these stem cells to be able to be used. And it's important for us to know when, where, so that we can harvest them on need to put them when we want to. So poll, let's do the poll. All right. Launching the poll, 10 seconds. All right, let's share the results. And yeah, obviously we all believe it's fiction, and yes, under certain circumstances, and yes, they can be found there. And I think all those answers are actually reasonable. I think it's simply a matter of, what's the situation. So let's stop sharing. Alberto, talk to me a bit about stem cells and where you get them from.
Well, I think in the office, the best place to do it for bone marrow is the posterior or the PSIS. It's been shown to have the most abundant or number of MSCs, and it's a really easy source to do. When I do adipose, a lot of times I'll go, if I'm getting bone marrow as well, I'll go through the same incision and get it from the flank or the buttock area. But obviously, depending on the patient habitus, you can get it from the abdomen as well.
Yeah, and Alberto and I, we did that study looking at the pelvis MRI analysis, and we were able to identify for the first time a safest method for harvesting of stem cells, and we did publish that paper a few years back. And I think that really gives us a more security that we're not going to hurt the patient. It's easy to do, it's reliable, it's reproducible, using ultrasound guidance to make sure we're in the exact spot we want to be in the proper angle, which applies to both men and women. I think it's something that can be done simply. I take them, of course, locally when I'm doing surgery, which works well. Sorry, Kyle, you're not allowed to talk today.
Yeah.
Whatever.
All right, let's get to the next one. Actually, Kyle, this is for you. Rehabilitation does not matter in biologics. And what's interesting is actually I have heard this several places. I've heard this where they say, "Oh no, rehabilitation not important." So, Kyle, can you talk just a bit about this? Whether you think it's fact or fiction?
Yeah, I mean, I really don't think rehab is very important anyway. So I would agree with you. So we can pretty much discuss that. Poof,
You just don't think you're important.
Yeah. And actually, it wasn't really important until even in the American Physical Therapy Association, they actually defined regenerative rehab. Basically, it is the integration of interventional techniques coupled with appropriate rehab protocols that harness the body's innate healing mechanisms through movement to augment the orthobiologic injections. Boom, mic drop. I actually wrote that. No, I didn't. But no, I think it's because it is a relatively new intervention. It is different than the traditional cortisone injection, in which you can skip the rehab because it's based basically on reducing the pain and getting back to your function. And if you're able to do both of those, then you don't really need any rehab. But with PRP, you can see we're already having like different indications. We're actually trying to get some healing.
Kyle, why don't you take another minute? I think you need some more time. Go ahead.
Okay. And so with that, I think it's very important that the physical therapist, the number one thing, they have to educate the patient. They have to educate the patient in knowing what are the different steps in the healing cascade. And just because they feel better next week doesn't mean that we can get them out on their sport. So in phase 1 is basically the inflammatory phase, and that occurs at the time of the injection to 4 to 6 days. So in that first week, we're going to be very gentle with the range of motion, maybe provide some low-level exercises, if any. But for the lower extremities like plantar fasciitis, Achilles tendonitis, we're going to go non-weight bearing in that first week. In the second week, we might have that proliferative stage, and that's going to be from day 4 to about day 14. I know there's some overlap, but we can start to increase the range of motion, begin some more strengthening, and then progress their weight-bearing activities during those 2 weeks. And then finally, we get to that phase 3, remodeling and maturation, where we have to eat, and then finally return them to sport.
All right.
Alberto.
Do we have to vote on this? Like,
obviously, I have a PM&R background, so I'm very partial. I think it's pivotal to have a plan after the injection. You can't just do a biologic injection and send the patient on their way. You have to think about bracing. You have to think, and by bracing, I mean short-term immobilization, weight-bearing precautions, and then I would get them into physical therapy within a week. For instance, when I do leukocyte-rich PRP in the shoulder, it can be very painful, even bone marrow concentrate. I'm concerned that patient could develop adhesive capsulitis. That's why I think it's so important to get them into physical therapy, cool off the inflammatory response, and start the early range of motion. So there's a lot of things that the physical therapy can do right away to make sure that this is successful. And then you have athletes who are very gung-ho and they're gonna wanna go quick. So you need a physical therapist to grab the reins and pull them back. So I think it's pivotal and should be part of any orthobiologic.
Yeah, and for me, this is pure fiction, of course. And anyone that knows me knows I've been working with Kyle for 20 years. What was interesting, when I first met him, I thought he was a bit of a kook with these wild ideas. It was not normal. It was kind of way out there. early motion, early therapy, don't really immobilize except for protected motion. And I suddenly realized after just a few months that my patients were doing significantly better in his care. And it became absolutely obvious that his methods of what he was doing made such a difference to my post-surgical patients. And so when I started doing biologics and injections more and more, trying to get people to get some kind of healing or other type of situation where they're going to get better with just a shot, well, that just rolled right in. And so now both Kyle and Robert, his partner, are in my clinic every week, helping out, seeing patients, making sure that the educational component is absolutely fall through on, so the patients do a better job and heal. So we are going to send a poll out, Kyle. We're going to see if anyone actually agrees with us, because of course we could just be making all this up, but let's see what people think. Oops.
Flyer.
That's what I was gonna say. Just give the patient a flyer. I love it.
Yeah, I wrote the questions, so
Do this at home.
I did the stems. You'll laugh though. I've actually heard doctors say, "No, I just give the patient a flyer." I've heard them say it, and it just blows me away because, I think for me, there's no question that it makes a difference because I've heard it from my patients. My patients feel so gratified that they have someone to help them along, that the educational component is key to their recovery because you make them a part of the team. You make them empowered to get better. I think that's critical with what you do, Kyle.
Well, I think once they get to that stage of getting a PRP injection, and honestly, when they are, it's a monetary thing as well. So if they're ready at this point to spend about whatever it costs, like $500 or more. But after, if us as physical therapists don't really understand and we get them going and a little bit too quickly, that effectiveness of the PRP can just go away. So I think it is really important.
I would encourage all the physicians to get one-on-one relationships with their therapists, bring them to your clinic, show them the type of injections that you're doing, and come up with a plan together and have a written protocol that you can follow. Obviously, it's going to be some overlap there, but at least have it.
Yeah, I agree. Okay, round two. Question, fact or fiction 3. Stem cell injections can regrow articular cartilage. So I'll start off. I've written a couple papers on this topic, and honestly, at this point, it's very clear. PRP is effective in surgical augmentation of scaffolds. There's no question that it can aid in getting cartilage to regenerate and regrow. And I'm showing you a video of one of my patients who had an implantation of biocartilage, and we were able to get that regrow, that area. In fact, this is actually that spot just a few months later. So there's no question we can do it now. That's absolutely possible. But what's also clear is that just generic injections into the area is not going to get it to happen. In fact, there have been numerous studies that have looked at post-operative PRP use, and once you have sealed off that area, that PRP doesn't do anything for that area trying to regrow. And so likewise, trying to inject it into a knee to regrow cartilage in isolation is not going to work. We're not geckos, we're not salamanders, we don't know how to regrow a limb.
I have to go with fiction as well. I think that this is something that I get all the time. Patients come in to see me. They have, advanced osteoarthritis. They want a stem cell injection to regrow their cartilage. And that's where I have to take a step back and try to educate them. So if you look at what a stem cell injection is going to do, it's going to modulate the microenvironment. It's going to try to induce some healing, but it can't turn an end-stage joint into a new joint. I can't restore your joint space. I can't regrow your cartilage. I can't remove your bone spurs. Now, that doesn't mean it's not going to work, right? Doesn't mean that it's not going to give you the effect that you're looking for, but you have to be transparent to the patient that, hey, your joint's going to feel better, but if we got another picture, it's going to look about the same. So it's very important to try to debunk those myths. Obviously, the milder the form of arthritis, the better these injections are going to do. We just have to keep that in mind and be honest and try to keep going with the technology.
All right, poll. Here we go. question number 3. Let's see what people think. Okay, let's share the poll. So we do have some people that think that stem cells can regrow cartilage, and the majority of the people do think it's fiction, and some when applied surgically. And I got a question through the chat saying that the question is regarding stem cells, not PRP, and you're absolutely right. That is correct. But the thing is, for me, it holds the same. You know, it's all about injecting it into a joint that's destroyed and seeing that it's going to be able to get rid of these the spurs and regrow the cartilage without it. I think, can it help surgically? Yes. And I think stem cells actually do work well, especially surgically. And that's kind of where my thinking lies as a surgeon, because I have gone in and seen some of these people that have had PRP, that have had stem cells, and then we've gone in surgically to take a look inside, and that just hasn't changed. And so I think if we're trying to, you know, just diminish pain, swelling, inflammation, I think we absolutely can do that. I think that is another question which we'll address next week about whether or not that makes a difference long term.
Right. That's what I was going to make the point that, hey, maybe we're not regrowing cartilage, but if we get it early enough, we're going to slow down the progression of the disease. That's definitely something we're going to be talking about next week, so stay tuned. But for me, basic injection, right now, I cannot regrow your cartilage. That's my answer. I'm sticking to it.
Well, maybe it's not just so much about regrowing, but when you're looking at the patient functionally, and if you're looking at possibly like decreasing that inflammation, well, we're going to get, if you decrease that range of inflammation, we're going to get improved range of motion, decreased pain, and therefore improve better function.
All right. Okay, question 4. OrthoBiologics will make me heal better, stronger, faster.
And I've been struggling with this one all week because I want to say fiction. And the reason I want to say fiction is more so because in the climate of orthobiologics, with some of the lack of literature and everything we've been through over the last 10, 15 years, I don't want to make it seem like this is it. Like it's better, faster, stronger. This PRP or bone marrow is going to be this magic stuff. But in certain situations, it can make you heal better. If you have a tendon that's been degenerated and has a poor blood supply, you can try to induce or activate the body's normal healing response to the area. So I think we should think about it more in those terms, that we're trying to activate the normal healing response, which hasn't happened. So we're not doing it better, faster, stronger. We're just trying to get it to happen. Now, has there been some data suggesting that maybe athletes can get back a couple weeks faster? I think the answer is yes, but that's a debatable literature. But I think it remains to be seen. But for me, I would be cautious with the statement because of what I said.
Yeah, and for me, that's exactly right. For OrthoBiologics is simply just taking what the body is already doing, can do, and harnessing it. So, you know, it's going to reliably initiate the healing cascade, diminish pain, inflammation, aid where existing anatomy biology is lacking. Like, for example, a patient that might have low platelets or low stem cells, like Hernigood did a great study looking at massive rotator cuff tears, looking at the tuberosity, seeing that there was a much diminished actual population of stem cells in that region, which means it's going to have a harder chance of healing. If you have diabetes, if you have poor vascularity, sclerotic, bad tissue. But surgically, if I do a surgery, I don't think in a year out that repair is going to be better, faster, stronger, or get better. But if you say, well, it wasn't going to heal, it was going to fail unless I did the biologics, okay, well, yes, then that's going to be better, that's going to be faster, and it's going to be stronger than a re-torn out area. So that's kind of where it is for me.
Well, I get to disagree with both of you because I don't know if you know this, Dr. Hirahara, but Dr. Panero and I, we did our own case study, and we got this guy much stronger, much better, and look at him, he is strong. But there are some side effects. His skin turned green and he had a high-pitched voice. But I do think that if we didn't have to worry about costs, and this was seen with a couple of the research, that there were 24 athletes with grade 2 hamstring tears, and PRP plus rehab had a return to play 26 days compared to 42 days. So I think there's some validity there. And I also think that in some of the baseball with the partial UCL tears, if somebody is pitching with an underlying grade 1 tear, their velocity might be down. And then once they get some of the injections, and if it went to a grade 2, we can possibly see this pitcher throw a little bit stronger or a little bit harder. So I think
All right, so let's send out the poll, see what people think. 10 seconds. That's an interesting one. All right,
Yeah.
let me share this. So people think this is fact, and I think from a specific
work, Panero.
Yeah. So from a specific point of view, I actually think, you do have a very legitimate point there. I think it comes down to what's the goal. So if you're taking a situation where you have an injury that's not getting better, and you then apply an application of biologic, you're right, Kyle. I think they're going to get better. They're going to get faster.
I'm sorry, you said what? I'm sorry, you said
You're
what?
right, Kyle. You're right, Kyle. But from my situation where I'm taking a surgical patient and applying the biologic, that's where I have a hard time saying that repair is going to be better with the biologic. Yes, it might more reliably heal, but not better per se.
Yeah, like I said, I'm torn. I think at the end of the day, I'm trying to be cautious just because I want to make sure that people don't take this and just tell every patient, hey, better, faster, stronger, right? I want to make sure that they're able to be transparent about what to expect and what these biologics are actually going to do.
So if cost wasn't an issue, and PRP is available for that person with a grade 1, grade 2 hamstring strain, why can't we just put it in there?
That's a legitimate point, Kyle. I think, though, however, that I think the question is going to come out. Well, if you drain the hematoma and then inject in the PRP versus just drain the hematoma versus do nothing, I think just getting rid of the hematoma is going to help. Adding the PRP on top of that, again, is going to, yes, potentially give that a better chance to heal. But that's a different situation than, say, a surgical repair.
Well, there's only 3 weeks left in the season. Can you help us out here?
Well, yeah. All right. Next question. Autografts are not necessary. Allografts, like amnion, have stem cells.
All right, so I'm going to tackle one part of that question there and say, well, with birth tissue or placental-derived tissues, we know that in vivo they have a population of mesenchymal stem cells that has been, proven in the literature. And in other countries, we can take those cells, we can isolate them and grow them in culture in a lab, and then re-inject them into our patients. But when we look at the products that are available in the United States, commercial products, from Wharton's jelly, from amniotic fluid, those do not seem to have viable numbers of MSCs. And we proved that, at least for the amniotic fluid population. We did the study that was published in 2019, where we took these to the lab at UC Davis and we couldn't grow any cells, any colony forming units. When we compared them to bone marrow, we were easily able to grow these colony forming units. So for me, I just want to make sure that at least in the United States, the commercial available products do not have viable stem cells.
Yeah, and I think that's a cool point, and I think it's a critical point. But, there are applications even without stem cells. And so, Alberto, I think one of the things that you showed in our paper is that, we have to have that utility belt. We have to have different options of different things to do different things. And one thing that's interesting about the paper that you were first author on is that you showed that there are things like bone morphogenic protein, hyaluronan, other growth factors in those amnion preparations, which may have been of benefit used in, say, osteoarthritis. So even though there's no stem cells like in an allograft, dermal, tendon, ligament, bone, demineralized bone matrix, placental tissue, amnion fluid, BMP, we know they have uses. Yeah. So just because it doesn't have a stem cell doesn't mean it doesn't have a use. But autograft tissue is still helpful, still necessary. So for example, if you want that stem cell, well, we're going to have to take it from that same person. So I think that's kind of the key point, is that there's many things, many ways.
Yep.
All right, let's go ahead and send out our poll. Launching the poll now, 10 seconds. Okay, ending the poll, sharing the results. So yeah, the majority do say fiction, a couple say facts, and I think it does come down to, in the end, what are we trying to accomplish, right, Alberto?
That's correct. I think at the end of the day, you very well mentioned that, hey, because they don't have stem cells, that doesn't mean that there's no use. I think for patients who are maybe of older age, have multiple comorbidities or on medications, that you don't want to use their blood, you don't want to use their bone marrow, or you just can't harvest it because of contraindications, that may be a place where you can do these amnion tissues that have growth factors and cytokines and can promote an anti-inflammatory effect.
But I think your point was well taken, Alberto. It'd be wrong of us to say that they have stem cells. You did find cells in some of these preparations, but they weren't viable. They weren't bioactive. They weren't actually able to be cultured out or be functional.
Yeah, that's correct. There were some cells that we found the viability was very low, and even the cell numbers, but none of them had mesenchymal stem cell properties, and we couldn't grow them down in culture.
Okay. Next question. OrthoBiologics do not work in the elderly. And I think we define elderly as Kyle, right?
That's correct.
Yes, that's right. And so for me, look, this is fiction. This is absolutely pure fiction. Gus Mazaka out of UConn showed us very clearly that when he compared, for example, two people, one young, one old, the effect on tenocyte proliferation for the ACP was the same. So we know that we can heal, and we've seen it. We've seen older people heal from injury. So to say that they can't heal is not right. And so we know that OrthoBiologics can work in elderly. Now, the big question is, well, to me, this is the place where it's actually most useful, because we know in aging, it does have reduction of cellular activity, less bioactive cells, and they can have sclerotic tissue with less cellularity. So the point is, adding biologics to these people, giving them a better chance to heal, is going to be very good. And so from my point of view, biologics is especially useful in patients that have poor healing potential, which also can include old people like Kyle.
I'm sorry, what?
I agree. I think that they will work in the elderly, and we should be using them. And I think you have to take the whole patient into context, right? There's some really healthy and young 75-year-olds that are still out there running triathlons, finishing them faster than me even. It's probably not that hard to do, but it is what it is. And I think there has been some data to show that there's not a negative effect, right? So Centeno reported this, 800 patients that he did bone marrow concentrate for knee away, and he found no relationship between age and outcome. So as long as the patient is healthy, they don't have any problems with their blood, their platelets, there's no contraindications, and you feel like their autologous tissues are healthy, you should use them for them to try to really boost up that healing response.
Yeah, I mean, I think definitely there's a lot of literature in there that OA is basically a condition found in most patients that are over 65. And there's a lot of research, like I said, some systematic reviews that compared PRP to cortisone to HA injections, and a lot of them favored the PRP. And I would have to say, for me, since I'm old, lateral epicondylitis used to be something that I just dreaded to treat. But with the intervention of PRP, it's been really nice. So after 4 weeks, if a patient is not improving, it's almost like I'm ready to refer them to you so that you can get that injection into that lateral common extensor. So basically, we had a 65-year-old with severe lateral condylitis, and he returned back to hunting, fishing, and yelling at umpires. And after 4 years, he still has not returned with any symptoms. So I think it's very successful and a very good option.
All right, we'll send the poll out. 10 seconds. So overwhelming fiction, OrthoBiologics do work in the elderly. Here are the results. And I think that is very much right on, honestly, and it's very interesting. One person did, in fact, send us a very good point that a higher PRP concentration is needed in the elderly, and I think that's a reasonable question to say, because these people already have a smaller amount of platelets sometimes to start with, and that's the key point. And so getting a higher concentration to use for these people to give them a better chance to heal, I think is exactly the point.
Yeah, and it also notes the importance of a good draw when you do bone marrow or when you do adipose. You want to make sure you're dead on and get a really good harvest.
I mean, I would even say like some of the patients that we've seen with frozen shoulder, that this is kind of a good adjunct for us to be able to increase their range of motion, decrease some of that inflammation, and they may not get the full range of motion back, but they do quite a bit better than before.
Yeah, I think that's key. Cool. Let's get on to our last one. Last question. I can bill insurance companies for OrthoBiologics.
This surprisingly is a fact. You can bill insurance companies, and you have workers' comp and even TRICARE paying for PRPs, more specifically for knee osteoarthritis and lateral epicondylitis. You do have to go through the proper channels and get authorization and make sure you do it the right way. If Medicare is not currently paying for PRP, but if you are going to do a cash-based procedure on a Medicare patient, you have to make sure that they signed the advanced beneficiary notice, the ABN. And more importantly, keep in mind, what your contract is with your commercial carriers, okay? Because a lot of times you're still required to request authorization and ensure that it's not a covered benefit, okay? Before you charge that patient cash. So make sure you understand that, make sure you know your contracts with each individual commercial carrier, and make sure you follow the rules and do it appropriately.
Yeah, I can't agree more. There's no question that it's finally coming around where insurance companies are realizing that there's a utility to orthobiologics. It's nice that they're starting to recognize that. Unfortunately, the Blues are not following, which has been taking a while. But we are seeing reimbursement finally starting to happen. Is it a lot? No. It's something, though, that you have to be very cautious. And I think Alberto said it very appropriately. Do the right thing. Just make sure you play by the rules and that you follow the rules. You bill appropriately. Make sure you get denials. You can charge the patients only after it's been determined to be a non-covered benefit. If it's a covered benefit, well, this is a ploy that the insurance company is starting to do, where they'll say, "Oh, it's covered, but we're not going to pay you." So be aware of that. We've started seeing a few of those come around, and that's a problem, because then if it is covered, you can't charge the patient. Don't do that. So this is something that we all need to get on board and fight those insurance companies and get what's ours.
All right.
Okay, let's go ahead and send the poll. Last poll, guys. Last one.
We're almost there.
We're almost there. Last one.
Oh man, we're having so much fun. We got to stop now. Come on, let's add a few more questions.
Okay, here are the results. So basically, it's a fact. It's true that there are some aspects to it that are hard. There's no question about it. And so it is a problem that is not 100% oh yes and no. I agree. And so that's definitely the issue. But Alberto, what do you think? Where are we in this today in 2021?
It is changing, and it's changing quickly. I can tell you from personal experience, several years ago, you would call the insurance company and they would say, no, it is not a non-covered benefit. Don't even think about it. And now when patients are calling the insurance carrier, say, no, 0232T PRP, yes, that's a covered benefit. So we're having to get authorizations and then submit the bill and see what happens afterwards. So it's a changing landscape. We have to keep a close eye on it.
What about the managed care? I mean, like, we're talking about private insurance, and workers' comp and Medicare, but what about when you have a managed care and you're trying to manage your costs? And this is pretty expensive. I mean, the equipment that you have, it's pretty expensive. So
I can't really agree with that, Kyle. Number one, we have had managed care pay for this. We have had authorizations. And frankly, it's cheaper than surgery a lot of times, especially when you can avoid it. All right, guys, great work. End of round 2. We made it through. I want to thank everyone for coming to listen. We're now going to go ahead and get started on our Q&A. I'm going to get rid of this. As I get rid of this, Alberto, why don't you get started with, how do you incorporate orthobiologics into your practice?
Yeah, so I think it's about starting the discussion early with the patient. A lot of patients may not know that orthobiologic is an option. So when they come in, obviously you want to get the correct diagnoses. And if you feel that an orthobiologic could be indicated, I go over the options. I tell them, hey, obviously you failed these conservative treatments. We could try a cortisone injection, for instance, in osteoarthritis, maybe hyaluronic acid. And then I go, and these are your orthobiologic options. This is PRP, this is bone marrow concentrate, this is how I use it. I go over the benefits and risks, and then I give the patient some literature. I also have updated my website to make sure that it has information that they want. And then from there, I allow the patient to make an educated decision about what treatment option they would like.
So we've got a couple questions. We're going to kind of try to answer as many of these as we can get to. Let's start off with Rachel Christensen's. Does the importance change based on the type of injury or damage being addressed? And to add, how about if it's an acute versus chronic injury? Alberto, why don't you start us off?
So does it matter, right? Acute versus chronic injury, is that correct?
Yeah, does the importance of PRP and stem cells change based on, or what you're doing based on the type of injury or damage being addressed?
Yes, absolutely. So, me being a leukocyte-rich guy for tendinopathy, if it's an acute injury, I am not going to use leukocyte-rich. I'm going to use leukocyte-poor because I actually want to try to calm it down and just allow the body's natural healing capacity to get started or do it right. So I do think that it makes a big difference. And if it is a chronic tendinopathy, that's when I'm going to go the leukocyte-rich route.
Okay, I would agree with that for you, but not for me. So I'm a leukocyte poor kind of guy. I see very few purposes of leukocyte rich. I would absolutely agree that if it's failed leukocyte poor, that trying leukocyte rich is reasonable. But being a surgeon, if I fail one therapy, I'm probably going to go straight to surgery anyways. Also, I've seen people have significant pain doing leukocyte rich, and so I have a very limited scope to use that. Lastly, you've got to remember, and I think this is a key point, the one thing I think that you may have a point is if you can do stem cells, because the stem cell specific gravity is almost identical with the white cell. So if you go with a leukocyte poor preparation of stem cells, you may not be capturing very many stem cells at all. Mm-hmm. So that's one thing that's a borderline question.
Yeah, all right. For me, I just want to add for the stem cell part, I do think that there is a role for acute partial tendon tears. That may be a role where you want to jump on it, kind of quickly. And that's where I would do my technique where I use the adipose scaffold and do bone marrow concentrate into it. Okay.
Actually, that brings up a great question. So one of the big questions is why PRP? What about compared to other biologics? Are other biologics successful or should we only stick with PRP?
Well, I think PRP has the biggest body of evidence, right? The biggest body of work. So I think that if you want to follow the evidence, you should use PRP and you should use it for knee OA, common extensor tendinopathy, gluteal tendinopathy. Now, if you understand the basic concepts of PRP, then you can dive into some of the other therapies, which, by the way, may not have as many level 1 studies, but they have been shown to be safe and efficacious in several lower level studies. So I think there's a role for everything, depending on what you're trying to accomplish.
Yeah, I would agree. I mean, when I talk to patients, I really give them like the menu and say, look, here's all the things you could try. Here's what we know about each one. And, do I know the perfect one to go for you? Not necessarily all the time, but I can give you an advice about kind of what might more likely work than another. And then follow-up question to that, which is a good one. So what can you do for someone who initially needed a knee replacement for bone on bone, but now because of health reasons, can't have the surgery?
Well, I'm going to tie into that with Jesus Sevillano's question too. For knee OA, do you recommend intra-articular, intraosseous, or both? Which, by the way, we're going to chat about next week in more detail. But I think that that's what I would do. I would actually look at not only getting an X-ray, but an MRI and look and see if there's subchondral edema. If that's the case, I'm not only going to inject intra-articularly, but I'm going to inject intraosseously as well. And then I'm going to put them in an unloader brace if it is affected to one side. I'm going to get them into physical therapy and potentially even consider like a radiofrequency ablation procedure just to dumb down some of the pain sensation to the knee. So those are all the things that I would do for someone who has knee OA, bone on bone, stage 4 to try to get them better. But I would be very transparent about what the results are going to be, right? So I'm not trying to pretend like I'm going to unbone them by doing these procedures. I'm just going to decrease their pain and improve their function.
Right. I want to answer this question. Does the type or brand of hyaluronic acid matter when combined with a biologic? For me, it's absolute yes. They are not all made the same, just like not all systems of PRP are the same. Definitely the different HAs are different. And the reason I say this, I've had experience with different brands and I've had problems. Like there's certain brands that cause an inflammatory response and have an inflammatory reaction, which I think is more of an allergic response. Whereas I've had others that have never had these responses. So the type definitely matters for me. Also, there's some newer one-shot injection HAs. I've had a fair amount of experience over the past few years trying those, and they work. I don't feel like they work as well as some of the other ones, and also they don't seem to last as long. So for me, yes, there's no question that the type of HA matters.
Can I jump in here? And I wanted to address Francisco Arroyo's point, because I think this is a great point to make. He is stating we applied 150 million of stem cells autologous from adipose tissue to 10 patients with arthrosis, and they regrow cartilage. I think he is referring to a procedure where you can culture the cells and regrow them and grow them in culture and get exponentially higher number of cells. So maybe I just want to make or clarify, when we talk about the stuff that we're doing, or for me, not being able to regrow cartilage is because of the stuff that I'm able to use in the United States. But I do think that his technology also still needs more data to back it up in larger studies. But in the US, we are not allowed to culture expand cells and re-inject them. But thank you for the point.
And I want to be real clear, we're talking about our experience in the United States with what we have available. And so we
Correct.
absolutely acknowledge and applaud the different types of things being done around the world. We're trying to follow that as well, listening to you guys, listening to what you're teaching us and what you're finding. So critical to have this exchange of information so that we can learn, because what we know with what we use, this is what we find. But there may be newer ways, newer technologies, which hopefully one day we'll get to play with and have the same outcomes you are. So thank you for sharing that, and want to make it real clear that we don't know everything. There's a ton to learn.
Yeah, no, it's great points.
Yeah. Kyle, do you have any questions you want to answer from this?
I'm looking at them, and I think they're primarily for you guys.
Okay, so let me answer this one. If a patient gets cortisone, how long should they wait for a PRP? I like to wait a minimum of a month, but it also depends where you put it. So if it's a joint injection, I think a month is a minimum time frame for me. Some of the more recent studies on cortisone have talked about 1 month being kind of that critical time zone when it really becomes critical that it's going to do a bad outcome. But the longer, there's no question, the better, in my opinion.
I saw a question that I wanted to address. Do the same rules for cane toxicity apply for adipose injection? I think in general terms, yes. But when you look at how we do, how we prepare the adipose, what we're doing is we're actually diluting, 50 cc's of lidocaine in 250 cc's of saline. So the cane does get diluted quite a bit. So it may not have as much of a negative effect on the cells, but I don't think that you can say it has no effects on the cells. And I think that still has to be determined a little bit better.
Okay. This is a good question. I'd like you to answer, Alberto, because I have no experience with this. Can you use PRP in sarcomeric damage or injury?
Where's the question?
It was in the chat.
Oh, it was in the chat.
Yeah,
As in a muscle injury, you mean?
Sarcomeric damage. I'm assuming she's referring to specific areas of the muscle. Yeah, is my assumption. I've not had experience with that specific.
Yeah, I don't have specifically with that, but have I used them for acute muscle injuries? The answer is yes. I think the data is very debatable on this, on whether to use PRP on acute muscle injuries. I think mistakes that have been made in the past is using leukocyte-rich PRP in acute muscle injuries, and that has created calcifications and problems. So if you are going to do PRP, I would definitely go leukocyte poor, and I would not concentrate the platelets very highly. There's also some data from Jason Dragoo that suggests that platelet poor plasma may be a better option for acute muscle injuries than PRP. So that's the best way I could answer that question.
Okay. From Dr. Sicilianos, asked the question, what about the paper on tenocyte proliferation? So that was a paper done by Gus Mazzacca. And I actually don't know what year he published. I want to say it was like, I know he originally did the study around 2010, 2011, I think it was. And I don't know when he published it. I don't think it was like 11 or 12. I don't recall, to be honest. So I apologize. I can't give you the exact date on that one. So, but if you look up Gus Mazzacca, Augustus Mazzacca is his whole name. I'm sure you could find the paper. When using PRP intraoperatively, what are your thoughts of using local lidocaine marcaine in ankle arthroscopy or mixing BMAC PRP with DBM and use for a fusion? All right, so this is an awesome question. Number one, local lidocaine, as Alberto said, is a wheel, or if you're going to do it, kind of under local, that's fine, but not in the site where you're going to use it. In terms of mixing BMAC PRP and DBM, this I do all the time. And actually, I've done a lot of presentations and talks about this. I use it routinely with ACL, specifically in two-stage revisions. So if I'm going to be backfilling an area with bone and I'm going to be using like a DBM or a bone allograft, I actually will take that BMAC and PRP and use it with it. And actually, that is the original indication, is taking bone graft with BMAC or with PRP as the FDA approval. Why does PRP continue not to be covered by insurance? I wish I knew.
Yeah.
I really wish. Do you know, actually, we had a meeting with Blue Cross about, I'd say this was about 9 years ago. And we asked them, how can we actually get the information about what they determine and how they determine what's experimental and investigational? And they said, well, yeah, we have that. Great. Can we see it? No. Can we talk to the people who are in charge of it? No. And we're like, come on, guys. So we have no idea, and we wish we knew. I'm sorry, I don't have an answer for that one.
There was one I wanted to talk, because you always make a good point about a terminal velocity effect. So yeah. I want you to talk about this, and what is the ideal concentration of over baseline? I assume it's in terms of platelets, and does it differ per type of tissue?
Well, that is a fabulous question. This has been debated now for at least 15 years. At this point, I think there is a terminal velocity because it's based not just on the amount of platelets you have, but also on the receptors that's in the tissue. And so from my point of view, if you're dealing with someone that has a baseline that's like, say, 100 in terms of their concentration of platelets, well, obviously going up 2, 3, 4, 5, 6 times might be better. That's not really a very big upcrease. And if you usually go 2 or 3 times, that's still quote unquote normal for someone else. So I think it matters what the start is, what the baseline is. And that's why we were talking about having more can be of benefit. But then at a certain point, you're going to saturate your receptors and you're not going to get a bigger effect.
Yeah, I think the answer is we're not sure yet. We used to think it was lower, like around 2 or 3 times physiologic rate. I think today, more basic science data suggests 5 to 6 times physiologic rate. But I know that there are physicians out there, for instance, Regenix has a 20x protocol, which I know they use a lot for different situations. I think the answer is we don't know yet, but we're trying to figure that out.
Dr. Vong wrote a very good question. Do you think someone who's had a lot of cortisone shots to the same tendon will benefit from PRP injections? Is there a point of no return in terms of saving and improving the tendinopathy? That is a fabulous question. We don't know 100% the answer. I can just tell you our experience, and I'll let Alberto answer after I do, because I know his is similar. But from my point of view, if they've had a lot of injections, that may have severely damaged the tendon. And if you have no vascularity anymore to that tendon, and now it's all degenerative, putting any kind of injection is not going to get enough vascularity to be able to get it to heal. So from my point of view, that's where I'm thinking surgery, honestly. That kind of gets us to a certain point. And that's why I don't like cortisone. However, we do know that you can overcome some of cortisone's effect. So, trying it out is fine. But if I've had someone that's had multiple shots of cortisone, now I'm going to be telling the patient, well, we might need to do multiple PRP injections. every 4 to 7 days, because we know in the studies that if you repeat a PRP within the time frame of 4 to 7 days, you get an augmentation of effect. If it's under 4 or over 7, you don't get that augmentation. So doing it weekly for about 2 or 3 weeks, you can potentially overcome those over effects and maybe work. We also have data that shows that there is a size limit on some of the damage to these tendons. And if over a certain size, in fact, it was about 0.46 centimeters squared, we didn't see a lot of good outcome in terms of healing on these larger lesions with PRP. And we actually used stem cells, we got a much better response. Alberto?
Nothing to add. You answered exactly how I would have answered it. I just counseled the patient that you may need more than one injection, or consider maybe just going straight to bone marrow concentrate.
Okay. Kyle, you have a question here. If the doctor applies a leukocyte-rich PRP and the patient likely comes in with pain, and I'm assuming we should not ice, no NSAIDs for this patient, is there a timeline that we tell them to deal with it before adding modalities to aid with pain? Great question.
Yeah, so I mean, I'm actually looking at pain as kind of like being my guide as far as like continuing on with the rehab and how well the injection is doing. So I usually tell them that it's going to be about like 4 to 7 days that they're still going to have the pain, but I really don't ice them either, because the amount of load that I'm having them do is going to be very minimal. So if they're still having pain, there's still something going on underlying. But I will tell the patient that they may not feel like they're any better until about like, I mean, it could be up to like 6 weeks, so that they can see a difference between how they felt before the injection. And from about 6 weeks on, you might start saying that you might start seeing some more improvement. And that's where we're seeing the improved function as well. So I really don't even ice our patients, because I don't really, only until they start getting to higher level activities. But other than that, I don't ice them.
Hey, Kyle, I have a question for you. What do you think about BFR blood flow restriction after biologic injection, let's say to a tendon?
Yeah, I mean, I think that at the same time, during that beginning stage, I probably wouldn't do it, because I really want the PRP just to stay in that localized area. And after about like 7 days or 7 to 8 days, it's pretty much absorbed into the system. So I think probably like don't disrupt the homeostasis of that area. But then I think after that, it can definitely be a good aid. So I probably wouldn't start it until like 2 weeks after.
Okay, thank you.
I think we're going to shut this down now, guys. You guys did an awesome job. Thank you very much. We did hit an hour and a half. Sorry for going over time.
Yeah.
I want to thank everyone for coming tonight, especially our long distance friends to come and listen and hang out with us for the evening. Thank you so much for staying up. We will have this up on YouTube. We will register everyone for next week's conference. Please come and see us next week and bring us some more questions. Really appreciate you all. Hope you have a great night. Thank you very much.
Thanks, guys. Have a great night.
Good night.